Good afternoon. Thank you for having me in this important Congress. It's a pleasure to share with you the results of this investigation, and I hope they are of interest to you. I will talk about amelogenesis general concepts, amelogenesis imperfecta, and some clinical and molecular studies that we have done in Colombia, as well as the perspectives for amelogenesis imperfecta. I will approach topics such as dental enamel, its formation process called amelogenesis, the genes involved in this process, as well as the proteins that are encoded by these genes. Also, I will cover reported mutations that cause amelogenesis imperfecta, as well as dental and skeletal anomalies associated with amelogenesis. And finally, I will tell you about the findings we gathered in studies done on Colombian families with amelogenesis imperfecta. Enamel is the body's hardest tissue. It does not contain living tissue such as vessels, nerves, or cells, and it is formed by tightly packed hexagonal enamel rods and prisms. An enamel prism is the basic unit of tooth enamel and is probably derived from the surface of the main Thomas process, measuring 3 to 6 microns in diameter and forming the hydroxyapatita crystal structures. In cross-section, it can best be described as a complex keyhole or a fish-like shape. The number of enamel prisms range from 5 million to 12 million between mandibular incisors and maxillar molars. It is not repaired, remodeled, or regenerated, composed of 96% mineral material and 4% organic material. Ameloblasts are the cells in charge of secreting enamel. Their origin is ectodermal, and as secretory cells, they contain a primary cell membrane, a cytoplasm rich in organelles such as the Golgi apparatus, the root endoplasmic reticulum, mitochondria, the nucleus, and Thomas process, which is rich in secretory vacuoles containing organic matrix, proteins, and numerous microtubules. On the other hand, the root endoplasmic reticulum synthesizes various proteins and glycoproteins, including amelogenin and enamelin, which form the organic matrix of the enamel and are packaged by the Golgi complex. Ameloblasts degenerate when the tooth erupts, after which time the enamel cannot be replaced by new synthesis. So, the ameloblast has the function to secrete an organic matrix of proteins that is later mineralized, and this process is carried out in 5 phases. In the first 2 phases, the ameloblast prepares itself and becomes mature secretory cell to begin the next 3 main phases. The process by which the formation of enamel, called amelogenesis, takes place is observed in this scheme, which shows 3 of the main phases in which it occurs. In the secretory phase, the ameloblasts form an organic matrix that contains proteins and proteinases. The latter degrades the proteins to allow ions, mainly calcium and phosphate, to begin the mineralization of this matrix, both in the 30% transition phase and in the maturation phase, where it is complete. These ions are transported from the bloodstream by the ameloblast. In this table, we can see the main genes that code for the proteins that form the enamel. The first three genes have been some of the most studied, and their function is for amelogenin, controlling the direction of crystal in enamel. For ameloblastin, participates in the differentiation and proliferation of ameloblasts, and enamelin participates in nucleation and elongation of hydroxyapatite crystals. In this other graph, we can see, for example, the FAN83H gene that participates in the differentiation of preameloblasts in functional ameloblasts and in the mineralization process of the enamel matrix. And we also see the genes that code for proteinases in charge of degrading mainly amelogenins such as enamelicin and kallikrein. Amelogenins are the proteins that are secreted in the greatest quantity within the enamel matrix, with 90%, while the remaining 10% correspond to non-amelogenins. The amelogenins interact with each other to control the formation, growth, and orientation of enamel crystal. Enamelin, which is found at 5%, acts mainly during the secretion stage in the structural organization of enamel and is the longest of enamel proteins. Amelogenesis imperfecta is defined as a hereditary disorder that affects the quantity and quality of enamel structure when mutations occur in genes that encode proteins involved in enamel formation, affect both deciduous and permanent teeth, with permanent teeth suffering the most. Its prevalence varies between populations, with the average global prevalence of 5% being the highest in Turkey and the lowest in the United States. Amelogenesis imperfecta causes patients dental sensitivity to cold, hot, sweet, and salty foods, cause poor nutrition and poor hygiene habits, caries, periodontal disease, and tooth fractures. Bullying has a negative impact on the dental aesthetics of children and adolescents in particular. The most widely used classification for amelogenesis imperfecta continues to be that of Whitcomb, where 14 subtypes are determined according to their mode of inheritance: autosomal recessive, autosomal dominant, or linked to sex, and phenotype: hypoplastic, hypocalcified, hypomaturative, and hypomaturative hypoplastic with odontism. The hypoplastic phenotype is characterized by thin enamel, pitting and growth, hard and translucent enamel. Radiographically, the enamel contrasts normally from dentin. Mutations that occur in the following genes are responsible for this phenotype. AmelX and ameloblastin stand out. Hypocalcified is another phenotype that occurs and is characterized by defect in the enamel that has a normal thickness. Teeth become stained and rapidly wear down, as we can see in this image. Radiographically, in the enamel, we can observe the lack of contrast between enamel and dentin. Mutations occur in the following genes that are responsible for this phenotype. FAN83H gene and amelogenesis stand out in particular. The hypomaturative phenotype presents the enamel of normal thickness but mature in appearance. The enamel has normal volume. On the other hand, the hypomaturative hypoplastic with taurodontism is a combination of hypoplasia and mature enamel with taurodontism, which is an anomaly where the crown is elongated and the roots are short. We can see this anomaly in this radiograph. Mutations that occur in the following genes are responsible for this phenotype, where the genes that code for proteinases are highlighted. In summary, until now, over 20 AmelX mutations have been reported, including large deletions, frame shifts, and nosen and missense variants. There have been 4 reported mutations in enam gene, 2 mutations in ameloblastin gene, and 11 mutations in enamelicin. Some dental anomalies have been linked to amelogenesis imperfecta, mainly taurodontism, congenitally missing teeth, delayed eruption, crown resorption, descendant, etc., as well as skeletal anomalies, the most common of which are open anterior bite and mandibular retognatives. Well, now I am going to tell you about some of the studies of amelogenesis imperfecta that we have carried out in Colombia. This is one of our first studies, which was carried out in 2007. We studied a family with the objective of identifying the mutations that had been reported in the literature at that time in exons 4, 7, and 9 of the enameling gene. We carried out pedigrees, clinical and radiographic examinations, as well as molecular techniques. The pedigree confirmed the autosomal dominant inheritance pattern, and the clinical and radiographic examination showed an amelogenesis imperfecta hypoplastic phenotype. In these photographs, we can see a severe generalized amelogenesis imperfecta that causes fractures, cavities, and bleeding on flooring. It was also possible to observe the characteristic growth in the upper anterior teeth. However, the tissue was hard to the touch. A new mutation was found in exon 9, where guanine was substituted by thymine in one of the alleles in position 1870, generating a change of arginine to methionine in codon 179 of the protein. Having this in mind, we decided to carry out a study of 5 families with autosomal dominant amelogenesis imperfecta. In addition, in this study, we analyzed the phenotype, clinical characteristics, and presence of mutations in the enameling gene. The condition for this study was that all families, regardless of phenotype, had an autosomal dominant pattern of inheritance. What did we find? 2 of the 5 families with autosomal dominant amelogenesis imperfecta had the hypoplastic phenotype, 2 had the hypocalcified phenotype, and 1 had the hypomaturative phenotype. This photograph shows one of the patients with a hypocalcified phenotype, showing wear in the contact areas. In this phenotype, due to the lack of calcification of the enamel, wear occurs as time goes by. Radiographically, the lack of contrast between enamel and dentin is observed, as are the radiolucent areas of wear. The pedigree shows the autosomal dominant inheritance pattern. In this table, we can observe the dental anomalies that were found in higher percentage of those affected. Dental agenesis, hypercementosis, and apical delacerations. We can see in this table which skeletal anomalies were found in higher percentage of those affected. Hyperdivergency, skeletal class 2, and retrognathis. Anterior open bite and mandibular retrognatism were the most frequent skeletal abnormalities in the families with autosomal dominant amelogenesis imperfecta. No mutations were found. Brought to our attention the fact that the new mutation that we reported in patients with a hypoplastic phenotype has not been found in this study, which proves once again that amelogenesis imperfecta is an entity with genetic heterogeneity. We have continued to carry out studies like these 2, which were published in 2021, where we found a prevalence of 0.6%. This prevalence is similar to that described in other populations. And in the other study, we sought to find the difference between amelogenesis imperfecta and incisor molar hypomineralization. And we found people with incisor molar hypomineralization did not present associated dental alterations such as taurontism, root delaceration, pulp calcification, or other alterations of structure, shape, and number, which were characteristics of amelogenesis imperfecta. In terms of skeletal characteristics, only 2 variables coincided: mandibular retrognathis and posterior rotated mandibular position. This study, published in 2022 in collaboration with Dr. Jung-Won Kim, discovered a mutation reported by this same doctor in the FAM FAM83H gene in the Korean population. In this study, we recruited a fourth-generation Colombian family with hypocalcified amelogenesis imperfecta. We identified a recurrent nonsense mutation in the FAM83H gene. The mutation would produce a truncated protein of 429 amino acids. This slide shows a photo of the patient with a severe hypocalcified phenotype. The pedigree shows an autosomal dominant inheritance pattern, and the sequencing shows the mutation. Impactation and crowd-resorption, anterior open bite, skeletal class 2, they were found. This is the first FAM83H mutation identified in the Colombian population. At this moment, we are conducting a study that allows us to determine the comorbidities in patients with amelogenesis imperfecta. We also have another study of the methylation profile and whole exome sequencing in Colombian families with this pathology. We are also looking for alternatives to remineralize the enamel of patients with amelogenesis imperfecta using native Colombian plants. Studies of amelogenesis imperfecta carried out in different populations have shown the genetic heterogeneity of this entity. Even among families, it can be observed that with the same genotype, the phenotype is expressed differently. For this reason, studies today must be aimed at seeking not only the manifestation that occur in the oral cavity, but also those that can occur at a systemic level, which can contribute to a comprehensive treatment of the patient. Studies that allow for the search for other diagnostic and treatment alternatives are necessary. A complete analysis that includes clinical and radiographic examinations and surveys that inquire about the patient's dental and skeletal anomalies and comorbidities should be carried out. This will allow a good diagnostic and the necessary inner consultations to achieve interdisciplinary care for the patient. Shukran. Thank you. Gracias.